What are some promising investigational agents and novel therapies in the relapsed and refractory setting?
So the two big classes of drugs that are very interesting for multiple myeloma is the bispecific antibodies and the CAR T cells. We'll have a few more that I'll get to as well. For the bispecific antibodies, of course, we have teclistamab that's approved, but we have several others also in the pipeline. So we have the BCMA targeted ones, we have elranatamab, alnuctamab, the AbbVie one, Regeneron. So there's a lot more in the pipeline. We have talquetamab that's targeting GPRC5D, so that's another treatment target. And then we have cevostamab, which targets FCHR5. So patients can respond to another bispecific with another target, even though they have been treated with, say, a BCMA one up front or earlier. Then we have the CAR T cells. These have been around for now a few years, the BCMA-targeted ones. We have CAR T cells with other targets, also GPRC5D. We're also now having a trial here with a dual CAR T, so we infuse two CAR T, BCMA-targeted and a GPRC5 targeted at the same time. And then we also have CELMoDs. So these are immunomodulatory drugs, and they have somewhat the same targets as the IMiDs, so as lenalidomide or pomalidomide. The new ones are iberdomide and mezigdomide. Those are very promising, very good results. And also what we're doing now is we're combining these in smart ways. So we're combining the already approved drugs with the bispecific antibodies, for instance. We have CELMoDs in combinations with approved drugs also coming with bispecific antibodies. And then for the CAR T cells, so far they have been a one-and-done treatment, but we're also looking into maybe maintenance after CAR T. So there's both very interesting new treatment options and new combinations and new ways of using them.
The question is, what are some of the novel therapies that are being tested in the relapse setting? And again, I mean, I think it's the era of immunotherapy. Now we are able to use the patient's own immune cells to eradicate myeloma. We can either take the immune cells out of the body, genetically modify them, and make them a myeloma killer cells. That's called CAR T cells. Or we can just give an antibody that will bring the myeloma cells and the immune cells next to each other and destroy the myeloma cells. These are the bispecific T cell engager. We have two approved CAR T cells in America right now, which is very exciting. And we have one bispecific T cell engager also just got approved a month ago in America. So that's really great news.
Talvey and Orexvio received FDA approval in August 2023 for myeloma patients who have received at least 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 monoclonal antibody.
I think we just need to learn about them more. So what we're seeing here, data at ASH, is about different bispecific that are available and probably will get approval soon. Different target for bispecific. The target that we've been using now for a long time is BCMA, B-cell maturation antigen present on myeloma cells and on normal plasma cells. But there are other targets that are, very exciting because they're different. So we are, the results are being presented and they look very promising. So I think that's really important. The other thing is that can we generate a myeloma killer immune cells that are not from the patient and they can be used? So because it's sometimes hard when you have a patient who's relapsing and you have to, wait to collect the T cells from them and then send them for manufacturing and wait for them to come back. Myeloma is not going to be waiting for that. So it would be nice to have off-the-shelf CAR T cells that are available to the patients. And there are studies being presented here about what we call allogeneic T cells. T cells from donors that are stripped from their ability to attack the patient normal tissues, but only kill the myeloma cells. That is really exciting. So, and then there are these called tri-specific, not just going after one target on the myeloma cells, let's go after 2 targets. And so there are, exciting data being presented here.
So right now, the only approved T-cell redirecting therapy is teclistamab, right? So there's a whole panel of other BCMA-directed therapies that are being explored, T-cell redirecting treatments. And I think those offer interesting opportunities because of alternate dosing approaches, perhaps slightly different side effect profiles that may make them easier to administer in the outpatient setting and so forth. Right now, teclistamab is administered on the inpatient setting because of the cytokine release syndrome that can develop that requires inpatient management in a small percentage of patients.
Talvey and Orexvio received FDA approval in August 2023 for myeloma patients who have received at least 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 monoclonal antibody.
And then the agents targeting other myeloma surface molecules, so the GPRC5D redirecting drugs are very encouraging, as are FcRH5 redirecting T-cell redirecting molecules. Those are very exciting molecules. And I think really it's how we utilize these agents both in combination with 2 redirecting drugs or in combinations with currently available myeloma therapies, standard of care myeloma therapies, or how we sequence them with CAR T-cell therapies. Those are the areas that I think are kind of the hot topics now of trying to understand how to incorporate all of this into a broader myeloma treatment paradigm.
To learn more about the drugs mentioned in this video, visit the link in the description.